Welcome to paulhober.com. We are delighted from Central America here to have Michael Chin with us. Michael, I met at a Denver conference I was talking at just last year in 2019. He was part of the Curamedics group, which I'm sure he'll talk about. And there was a great moment where they got some of the key opinion leaders in America up on stage, and Michael had some real insightful points to make, and that was the moment where I said that guy has to come on paulhober.com. So why do we do these interviews? It's because when we go to conferences, the speakers all get to have a chat over lunch and over coffee, and this is where learning really takes off. And I think it is so vitally important that we try and bring those conversations to people that perhaps don't have the opportunity to do it. Tomorrow for DJO, I'm doing a online presentation, a Zoom conference, if you will, and there's more than 300 people from around the world that are going to be logging in and doing that training with me tomorrow on radial pressure wave in the upper body and upper limbs. And that is truly incredible. I've been teaching this for 7 or 8 years now, and 300 will be the biggest group outside a conference that we've ever had. So it shows this stuff is growing and growing at a rate possibly faster than coronavirus. Michael, welcome, and thank you so much for giving up a piece of your morning to join us.
Paul, thanks for having me. It's awesome to be here.
Thank you very much. Michael, what I would like is for you to give us just a couple of minutes so that those people that don't know you understand who you are, what you do, and why you love shockwave therapy just so much.
Sure. I got into shockwave therapy probably about 10 years ago. I have a practice in Chicago, Illinois, right in the middle of the United States. We are a practice that treats probably about 90 to 95% athletic population. The program or the clinic name is the Running Institute. And that started actually and was born through a kind of realization that the running boom started to really hit in Chicago. Chicago Marathon became a huge, huge success, starting to get up on the upwards of about 40 to 45,000 runners a year. And we developed a really good relationship as volunteering through Chicago Marathon to provide medical services, podiatry care, podiatric care in that case. And as I worked up the ladder, I became the co-lead for the Chicago Podiatric Medical Tent. So the marathon has been a huge, indwelling of patients, obviously also successes with treatment, thinking of things that are outside the box, especially something like radial wave, which was the first shockwave treatment that we offered. And then kind of the foray into the focus wave unit, which we received about maybe 3-4 years ago. And just seeing the outcomes of, pressure wave therapy has been unbelievable. It's been, I call this, and I think many people do, it's a game changer in our practice for non-invasive things that are scientifically proven to provide treatment to patients who are maybe otherwise hurt and not able to run or not able to do any exercise, even garden variety athletes who are trying to get out there and just, shed a couple pounds.
So in terms of the sort of things that you see then, what would be the 2 or 3 main indicators? Or you can have 5. I mean, I don't care how many you have, but what would be the key indications that you would treat where you would be pretty much making a beeline for one of the 2 types of shockwave treatment we've mentioned?
Definitely plantar fasciopathy. I would say that's probably our number one. We see probably close to 1,200 cases a year of heel pain, not necessarily, plantar fasciitis. We do Achilles tendonitis. I actually started using the focus wave for things like stress fractures, early onset stress reaction, bone contusions. So you name it, there's so many implications and applications that we can use it for that it just keeps growing. And I started using it for nerve pain, specifically when Karsten was presenting at one of the conferences that you and I both attended. And he gave us this, chart of how to maybe titrate the different tissue pathologies. And I'll tell you, that has been a an amazing improvement in terms of my outcomes. And even if I have a patient who has a plantar fasciopathy case and they had an underlying nerve case along with it, I've changed the protocols to be able to kind of treat the nerve as well. And seeing those patients literally just 2 weeks ago, starting to see some massive improvements from just titrating the nerve pain aspect of it. And he's back to playing a little bit of basketball, and he's doing some running, which he hadn't done in almost a year and a half.
No, it's amazing. And ultimately, we all decide to go down this route of healthcare because we want those stories, don't we? We've got science over here, we've got our experience here, we've got all the methodology and the protocols, and we bring all that together. But ultimately, the end goal is seeing that patient going off and doing the things they love to do, and that we, as practitioners, I suppose, have put that drop of oil in the right place. Ultimately, they've got to do their rehab and whatnot. So talk us through that protocol. It sounds really interesting. So when you're working on plantar pain and then you're looking to titrate the nerve, how might you use the two bits of technology, and what kind of settings are you hitting and stuff like that?
Sure. So settings for the focus wave, and I know people start either with focus wave or radio wave. I have a tendency to start with focus wave on patients, and I'll do 2,500 pulses. I try to start them at about 0.15, 0.14 in that range. And as I bring that up for the fasciopathy component, I bring that up and I try to get them to about 0.25 to 0.3. And if their pain levels are, 4 or 5 on the pain scale out of 10, then I kind of keep it at a level that's, comfortable to the patient. I do about 2,500 pulses there. Then I bring in the radio wave, which then I bring up to about the same. It's about 2,500 pulses. And I'll do somewhere in the range of about 4.0. If I can get them to 4.0 bar, get them to that level. Same thing, titrated to pain scale about 4 to 5, unmedicated, no local anesthesia. If I do 4 sessions of that, and I do 4 sessions a week apart, and I'm seeing that the patient's doing well, their numbers are dropping to about a 1 or 2 on the pain scale, I hold pat. And I kind of tell them that, it's going to be about 10, 12 weeks to get the full effect. We'll do ultrasound to kind of, identify how the changes are improving in this case, see if the tissue starts to remodel. At about 6 to 10 weeks, we do that ultrasound and see how they're responding. If they're still having some pain at about the 3 or 4 week mark after that treatment, what I'll do is I'll take a look and see if maybe it is more kind of medial calcaneal nerve branch pain. And I'll use a setting at focus wave wise at about 0.1 or 0.07, which seems like really nominal. I mean, it's really small, but what's strange is that, as Carson kind of pointed out, Dr. Knobloch, his chart actually shows that nerve is actually much thinner, and it's a much softer tissue. And if it's engaged in scar tissue, a lot of times what you can do is desensitize it and even mobilize some of that scar tissue with a lower setting, which I thought was interesting because, I always thought that those settings were just kind of garbage settings. But when we kind of dial it down to that, we started seeing nerve, pain respond. That's been a game changer. And that's about 2,500 pulses as well. So I stay around 2,500. In some cases, if a patient is really large, I'll kind of increase maybe the number of number of pulses to about 3,000 if they're a patient of a larger BMI, or maybe they're 6'7" and their plantar fat pad is massive. We'll increase the number of settings just to kind of get more tissue modulation.
And then do you back this up then with orthotic insoles and strength conditioning work and stuff like that? What else are you throwing into the bargain?
Absolutely. So I do orthotics, and I've lectured on this throughout our country here. More of an EVA style device, something that's softer, something that has a little bit more cush, but still has kind of the form to the arch. So I do a deep heel seat. I'll use, like I said, maybe like a Spenco top cover just to kind of disperse some of that pressure. But what I like about the EVA device is that there is a little bit deformity, or what we call articulation at the heel, that allows the heel to kind of impact and kind of ease into the next round of kind of the gait process. And then I'll incorporate physical therapy a lot of times. And strangely enough, that's one of my largest referral sources in the States is physical therapy. Because up until last year, they were not direct access. So you had to actually have a physical therapy referral to send to the physical therapist to be able to perform treatment. Now there's direct access, but that still hasn't changed our approach. Like I view physio as an amazing piece, more for kind of titrating in, obviously, strength and balance exercises, because there is obviously intrinsic atrophy and weakness. But then also we do a lot of video gait assessments through the physical therapist's office. They have Dartfish, or they have another video assessment tool that allows us to kind of see where the weaknesses are actually generated from. So, I kind of use the analogy of a good diagnosis leads to a good treatment plan. And if you have a good idea of to where the weakness is, you can delve in and titrate a really good physical therapy plan with that. And I think that's where kind of the well-roundedness of all this really comes into play to get our patients back full strength and not have the downtime that you would usually see with heel pain.
Oh, that's brilliant. And then, do you have a your business is predominantly runners and stuff. So do you then have a kind of a return to play kind of program that you work with them in terms of what running they're doing and stuff like that afterwards?
Absolutely. And we do a lot of dynamic warm-ups. I know your book. I just received it actually yesterday. So I love it. It's got the information that I share. It's like somebody was talking out of my own heart. But the dynamic warm-ups is a huge piece. Post workout, definitely the stretch. I also use tangential things like hypervolt or Theragun to kind of get the tissues modulated that way to loosen them up. I use Spara tool, post activity. But to get them return to run, I use the Heiderscheid program, which is based out of University of Wisconsin. And this physical therapist, who's a doctor of physical therapy, had developed a return to run program that's been widely accepted throughout, the universities and collegiate athletics to professional athletics. And it starts out with a 3-day-a-week run. So it's Monday, Wednesday, Friday, Tuesday, Thursday, Saturday, 30 minutes. And it's an interval run that starts out at a half-minute run, 4.5 minutes walking, and then the next day you add an increase of a half-minute run to the segment, and you remove the half-minute from the walk segment. So by the time that you hit 4 weeks, you're hitting at about 30 minutes straight through. And then once you do that, we increase the run segments, again, 3 times a week, 30 minutes, but then you can increase based on time and or distance, 15 to 20%. So a lot of our patients are training, for example, Chicago Marathon. They have to have a base of 6 miles. We're going to try to get them either time-based or, distance-based up to that, time, so they can get their training programs underway.
Oh, brilliant. So I guess my point of delving down there is that some people are, I believe, using Shockwave, and hopefully they're in the minority, where that's all they do. There's no other stuff around it.
Right.
And yet the people that are the naysayers, the people that want to prove that they think Shockwave doesn't work, they then criticize the likes of you and I because we're doing all this other stuff around Shockwave. So what's your experience of doing exactly the modeling that you've explained there with the orthosis, with the physical therapy, with the ultrasound imaging, all of the package you said, and the return to play running scheme? What's your experience of using just that, or that in combination with Shockwave? How do those two things run parallel?
Well, it's interesting because there are people who practice really close to me that have a radio wave, pulse wave box, and all they do is Shockwave, and they don't do any of the adjunctive pieces. And it's interesting because I see those patients a lot of times as second opinions. We're talking, probably between 4 or 5, every couple of weeks. And they're like, yeah, I paid for this unit to treat my heel pain, and it got either worse or it got mildly better, and then it flared back up again. And I asked them, the first thing I asked is, did you do physical therapy at all for it? And they said no. The doctor said that the Shockwave should take care of it once and for all. This is the cure to your plantar fasciopathy. And I would say that our success rates are probably close to 85%, if not higher. I do have some patients who I would say, again, kind of driving down to the diagnosis, we do in-office ultrasound, so diagnostic ultrasound or MRI, depending on the patient's level of pain. And I've had a couple patients where I thought it was straight up plantar fasciopathy, thickened plantar fascia, no intrinsic tears, and then ultimately found that they had an intrinsic tear to the plantar fascia. And one of the things that kind of came about was, well, what do we do with intrinsic, tendon tears or plantar fascial tears? And it was about the time that I started delving into amniotic injections, and found that when I titrated both of those together, that I actually got those patients at 100% success rate back to their full activity. And some of them were pretty sizable tears. Then I was using them for, partial medial band tears or central band tears, in isolation. And we probably have close to 75 cases. This is actually, we're working on a fellowship this year to try and get a sports medicine fellow in our practice to do some research and take those numbers and actually look at it and put it to paper, because it's anecdotal response at this point. I have, doctors, across the nation who are using this protocol, and the numbers are really good, but we don't have a paper that actually shows a good scientific evidence behind it. So when we, couple those together, it's been outstanding, and avoiding then a surgical procedure, which typically is what happens when you have a partial plantar fascial tear. You go in, you do an endoscopic plantar fascial release or open plantar fascial release, and that person's down for quite some time. You're looking at probably 10, 12, 14 weeks of downtime, where if I do this combination of treatment, I can get them back typically to running at 6 weeks, which is outstanding. And it is, again, a regenerative reparative process that we're doing instead of, stripping the plantar fascia away.
And so for those that won't be au fait with amniotic injections, just give us a little elevator pitch on those, what they consist of.
So the way I kind of, see it in kind of layman's terms is that in the case of a tear, Achilles tendon tear, partial plantar fascial tear, is that you're prepping the land, you're kind of getting the soil prepped with the EPAT, Shockwave treatment. And then when you add the amniotic injection, you're adding kind of the seed, or that, in this case, you're developing something that's creating collagen, and it's a stem cell activator. So you're actually getting stem cells within your own adult body to kind of create then that tissue. Once you hit those EPATs, so I do 2 EPATs on the front end. The second EPAT, I do an injection. And then the following 2 EPATs I do in sequence, just as I do for a traditional EPAT protocol. And what I get is that 2-week window, prep the land, inject. And then what I do is, if it's a significant tear, I'll immobilize them for 2 weeks. That's it. In a cam boot, walking boot for 2 weeks. And then based on pain tolerance, I'll kind of wean them off the boot at about 2 to 3 weeks. And when those patients then are off the boot, then they start physical therapy. And that process of, the amniotic injection plus EPAT, I tell patients it's going to take about 10 to 12 weeks for the full nature of that tissue to repair. And we'll look at it again, kind of in the same note with ultrasound diagnostically. And it's amazing. I mean, like I said, I would put that over, doing an operative procedure any day. Is just, now kind of getting the buy-in from, people who are evidence-based, medicine, like-minded folks like myself, to then say, this is valid. These numbers aren't just, anecdotal. They're the real deal. So.
And of course, this is where a lot of science comes from, isn't it? You get people that combine two very good therapies, and they find they get a greater result. And they're going, my God, we're on something here. And then the science oftentimes will follow behind to prove what you already know. One of the things about shockwave therapy, which always astounds me, is there are close on 300 academic papers coming out every single year.
Right.
And that's been pretty much for 40 years. Why are we still, as clinicians, having to prove ourselves in this world of Shockwave? Why is it that we've got way more research coming out than just about any other modality that I can think of, and yet still there are people going, this doesn't work? Do you have a take on that from the States?
Yeah, in the States, it's interesting because insurance, especially when you're talking about private insurance, they're not in the mode of paying for things that are preventative or low invasiveness. They're willing to pay for the big surgical procedure, right? They'll pay thousands of dollars for a surgical procedure because most people aren't going to go that route. They'll just wait it out. They'll wait it out. And I think insurance companies know darn well that people are creatures of habit, and they're going to take the path of least resistance, right? Even though it's covered by insurance, they'll be like, I'll wait. My knee, it's hurting for years, and I'm not going to go have surgery on my knee because I know what the downtime is going to be. So when it comes to the studies, I think everyone's trying to prove the same thing, that it works, and we want it to get covered, strange enough, by insurance companies. But at the end of the day, I will tell you that I prefer it not getting covered by insurance, because I think the influx of the number of users will certainly overwhelm the system. And then it starts out maybe paying at a ballpark number. Say it's $250 a session. And then all of a sudden it drops down to $25 a session. And I was on an insurance panel for our state, and we went to Blue Cross Blue Shield of Illinois, which is our largest carrier. And that's what they wanted to pay us, was $25 per session. And we know how much that unit costs out of pocket. It's more than my car. Okay. So if I'm getting paid $25 a session, I have to do a lot. And, for all intents and purposes, I enjoy providing treatments to my patients, but it also has to be financially, sound. And to the point where I'm not, I hate to say it, but sucking wind in terms of my, monthly payments that I have to make on this expensive machine. So, the science is there. There's 300 papers, like you said, coming out every year. And for what it's worth, I can't understand why it's taken, maybe the orthopedic communities in the world, even my podiatric colleagues in the world, to take so long to get on board with something like this. It's a no-brainer, really, at the end of the day.
Yeah, it's interesting for me that some of the that from Australia, for example, Jill Cook, who is all about tendons, and a lot of people follow Jill Cook. She's been really quite damning about Shockwave in the past, saying that has no place in tendinopathy repair and all this sort of stuff, and that was quite damaging because lots and lots of people listened to her. And then someone that she's close to, Pete Meliaris, he's now doing quite a large-scale study on Shockwave. And Jill Cook is now starting to, I understand, I've not heard it from her directly, so I understand she's starting to come round to the notion. And I think that her journey will be similar to many in that, okay, I've heard about this a lot. It's almost like seeing advertising for a new thing or a new TV series. You need to see it 10, 15 times before you start to think there might be something in this. And I guess the more resistant people are to it, they build up a barrier. They then come to it a bit later. But once they start to look into it, and their confirmation bias changes from I'm 100% set this doesn't work to there might be something in this, suddenly all these doorways open up to them, and they start looking at it through fresh eyes, where there's even just a slight consideration that this might work. And then they seem to have this exponential rise in their understanding of it. Then they start using it, and the anecdotal stuff comes in, and then you've got a new advocate. And it seems to me that we've got some of the biggest naysayers, the people that absolutely shunned Shockwave initially, are now coming round to the fact. And I think once those people are joining us and doing things like this, and more, yet more science comes on board, I do very much see that shockwave therapy in all its forms could well become, I believe it will become, one of the first things you use in a lot of medical settings. Actually, it's quite topical at the moment, but given how coronavirus is killing people by literally blocking up the lung tissue, it strikes me that if I were in that position where I looked like I was going to die, there's one thing I'd be asking for. I'd be saying, shockwave my lungs, because I know it's going to mobilize, I know it's going to regenerate. And I was at a quick chat with Carsten saying, could we not be on to something? You know, could shockwave not actually be delivering something towards coronavirus that people wouldn't have thought of? And he said, well, the problem is we have no evidence. So who do you choose? How do you get the ethics on who to choose? But he said, I, like you, think that there could be something in it. You know, what would your thoughts be on that?
Yeah, I mean, I think, you know, given any situation like this, what's, you know, so dire, and, you know, obviously healthcare providers are obviously putting themselves at risk, and obviously the aging population obviously is the biggest, you know, biggest in effect right now. That why wouldn't you try it, right? I mean, there's no harm, there's no invasiveness. The ability for tissue regeneration, or, you know, breaking down scar tissue. I'd say you just basically, you know, have that machine humming throughout, you know, the treatment centers, and see who's responding. And if you get, you know, 10, 15 patients that are responding, I can't see why not just, you know, opening up the floodgates and getting treatments on board. I mean, it starts, like you said, with anecdotal, you know, treatments. And if you get, you know, 5, 10, 15, 20 patients responding, then you start, start thinking that obviously at some point you got to put a paper together, but, you know, there's no harm. You know, the first do no harm rule applies to what we do in medicine. And that's the beauty of shockwave treatment, is that there's no harm. It's not comfortable to get the treatment, but there's no harm. There's no invasiveness that we're providing. It's actually less invasive than intubation. So, you know, it really, you know, to your point, kind of hits obviously some really, you know, poignant pieces that we could use something that is, you know, so novel to, you know, fight something that is just, you know, it's deadly, right? So that's a great idea.
It'd be very difficult to say to a patient, "We never tried this before. It looks like you're dying. Why don't we give it a go?" And then that person makes a full recovery. That's great. But if that person still dies, that's unfortunately where, you know, this thing comes on top, doesn't it? So I don't know how you get it in there, but I'm saying, if it were me personally in that position, you know,
sure.
my last breath would be, please shockwave my lungs. You know, that would be where I'd be. So is there something from the scientific community, a book or a paper, which you think has been a big game changer? Is there one piece of evidence that you have this go-to relationship with?
Yeah, I mean, I'd say that, you know, the first paper that I started, you know, with was certainly by Luger Gerdes-Meyer and Amal Saxena. I had the, you know, pleasure of, you know, doing my residency with Amal out at Stanford and Palo Alto, and it was kind of his early, you know, times in which he was starting to use EPAT Shockwave, and he would kind of talk about it, and certainly, you know, that kind of got my interest. And then certainly Karsten, you know, when talking to Dr. Knobloch at the meeting and seeing his you know, papers and things in the periodicals that Pure Medics put together with Storts, I thought that too was, you know, really kind of mind blowing, because we never knew that there were, again, treatments that you can do by titrating those numbers down to a level where you're like, those are microscopic levels, those are really small. So I'd say those are probably the people that I look up to in terms of shockwave. Strangely enough, the person that got me into shockwave was a person who mentioned, sorry, my dog is having a banana.
That's all right.
Yeah. Let me close the door here. That actually Rob Connell was the first person that I spoke to about commercially using Shockwave in my office. So I know Rob was on last week for a conference with you, but he gave a more personal approach to it, which I love about Rob. We say like brothers. He is my brother that, you know, I've known for roughly now about maybe 5 or 6 years. But what's awesome, or actually longer than that, I guess I've had EPAP for 10 years. My goodness, it's been a decade. But he is a guy that keeps it real. He keeps it real. He's like, dude, this is how, you know, I see my patients, and I'll, you know, throw the treatment protocols out. He's like, yeah, I do that, but then sometimes I'll add a little bit more. I'll see how things go. There's not as much as you want to put science behind it. This is an art, and you have to be able to titrate and modulate the treatment for each and every patient. Not every patient's going to be the same. Not everyone's going to walk in with 4 treatments or 5 treatments. They may do well after 3 and they're out the door. But I'd say that, you know, on average, it's about 4 or 5. And he's like, you know, you have to be, you know, mindful of what the patients are feeling, listen to the patient, talk to the patient, and get you know, a deep history behind it. I think that's what we do really well as podiatrists, as physical therapists. We all talk to our patients. We're not standing and looking at an image and, you know, telling people what they need to hear and then not touch the patient. We're very tactile. And I think that's really important to providing, obviously, good care to our patients. You have to put your hands on them. And if you don't, you're not doing your job. And that's where telemedicine right now, it's so hard. You know, I'm treating patients with televisits, which is nearly impossible. But, you know, we're doing it, but we're listening to patients. We're talking to the patients, and they're getting it. They're getting FaceTime, no pun intended, but they're getting FaceTime with us to be able to kind of talk through their problem psychologically, emotionally, and, you know, physically. So it's an interesting time nowadays with this pandemic in place.
Yeah, it's interesting that you should say that point, because we've got pain scientists who are saying, like, you know, stop touching your patient, should be able to talk someone through it. We've got manual therapists that, like, I just can't do what I do without touching them. And I don't think that those two groups are ever going to really agree. What's interesting is that I've been talking to a lot of therapists in the UK about how their, you know, televisit, Zoom treatment, whatever is going. And they're really, really struggling to get people to come on board. Some people are talking about between 1% and 5% of their client base are taking it up. And I said to them, well, why do you think that is? And they said, well, because people want that physical contact. They don't see how we can do our job by just talking to them. If that was the case, then, you know, they'd go on Google or read a book. You know, they want our expertise and
right.
And they want us to use a hand. And so it's, if the pain scientists are right that we don't need to touch our patients and manual therapy is terrible and all that sort of stuff, then definitely the patients haven't got the memo yet. And manual therapists around the world haven't got the memo either. And it seems like it kind of puts the pain science side of things into a minority in terms of people that want to do purely that. I like pain science. I talk to my patients about the relationship with pain at the same time as I'm working on them physically, and at the same time I'm using Shockwave, but it comes together as a bundle. I don't think that the day will ever come where I'm going to have this metaphorical kit bag of all the things that I can do with a patient and choose, I'm only going to take one with me to work today. And it's just going to be that one. Because as you said, you treat the patient, and each patient needs something different. So if you're just going in with one, you know, weapon, if you like, then, you know, you're going to miss out on a huge portion of patients. And telehealth stuff is a big ask. I think that it will start to go up in the curve in the UK as people are unable to cope with the pain they're in. But it will mean that telehealth visits are going to be in that top portion of people that are in agonizing pain. I don't think we're going to see the people who can manage at the moment. So we'll see how long lockdown is, and whether those things really start to come to fruition. But they are interesting times, for definite. Michael, I love the conversation we've had. It's been amazing, and I'm conscious not to take up too much of your time, but it's really important. You've seen from the other videos that I do that I tease out of you things that maybe I already know. And Rob, blindsided me with his story. I had no idea.
Yeah.
But I think it's really interesting because at future conferences, people are going to go, oh, there's Michael Chin. I've seen him, doing some stuff, and they might want to come up and have a chat to you. And unless you want it to only ever be about Shockwave, then we need to tease out a few things. So what maketh the man? What is help us to understand who Michael Chin is. What are the things you love doing outside of working?
I definitely enjoy bourbon. So I'm a bourbon guy. I have quite a few collectible bourbons in my collection. I love golf and I play tennis. So those are two athletic activities. I was not, strangely enough, I wasn't much of a runner. I only did it for cardio, for, conditioning. I have a knee that's been pretty beat up from an old meniscal tear on my left side. And now I'm getting a bit of the same symptoms on my right. So running, unfortunately for me, has not been a very comfortable thing over the past couple months. But I've taken up a little bit of cycling, which it's very little. I still get a little nervous, obviously, with the pandemic going on to go out for a ride. It's so congested in the city. But I have two lovely kids, 11 and 7, who I've enjoyed the moments of e-learning while trying to also work. I have a lovely wife, Shannon, who's working full-time and trying to do e-learning, which is awesome. But we enjoy vacationing, obviously going to places that we've never been to. And we like to adventure, which this really puts a damper on things. We had some plans for this year to go out and do some travels. And just like many, I mean, it's been a game-changing experience with the pandemic involved. But I love what I do in terms of my medical practice. Unfortunately, that tends to be what occupies a majority of my time. But I love, going to conferences and speaking with obviously like-minded people or non-like-minded people to kind of get their opinion, which, being able to do that and then socialize and be able to kind of, meet new people like yourself last year, it really gets my juices going to kind of look at this whole medical experience in a different light. So.
Oh, amazing. And what breed is your dog?
My dog is a mixed breed of terrier. They said Lhasa Apso and Spaniel mix, which was supposed to be a non-shedding dog. But then we found out that a majority of her is terrier. So hence the barking and going after things like squirrels and vermin that run outside of our townhouse. So yeah. She was a crazy dog, and we considered actually getting another dog during this whole pandemic. So we're crazy on top of everything. So
yeah. Oh, it's brilliant. Well, she made a welcome introduction to herself, anyway. And I'd be interested to find out about your bucket list. It's something I ask everyone. What would be number one on Michael Chin's bucket list right now?
Bucket list, I would say I've been really wanting to explore a little bit more of Southeast Asia, so like Vietnam, Thailand. I've been to Hong Kong and mainland China, but to be able to go and check out, obviously, the southeast side. The one thing, I love cooking too, so that's a big thing. So being able to go out and check out, obviously, the food scene there. The food scene in Chicago. If anyone's ever in Chicago, please, hit me up. There are many places that I can tell you about. Favorites here, from the hearty to the healthy, but and certainly pizza, which Rob would disagree because he's a thin New York pizza guy. I'm a deep dish guy, so there's a battle there. Even though we're brothers, we like different types of pizza. But yeah, definitely Southeast Asia would be my next adventure for a bucket list. And
then the UK, you've got to come visit me.
Oh,
too.
UK. Strange enough, I studied in Lancaster. I actually did a year in Lancaster on the east or on the west coast. So my wife also was 6 months at Lancaster the following year. So we both were in Lancaster. We didn't meet there, but we actually, when we met, we actually started talking, and have you ever studied abroad, or have you ever gone overseas? And we both came upon the fact that we both went to University of Lancaster. So I do miss the fish and chips. They were solid. Served in a newspaper. I mean, it was legit. That place was packed. Lines going out the door. So.
Oh yeah, on a Thursday and Friday. Lancaster's about 2 hours from where I'm sat right now. I could be there in 2 hours.
Oh, get out!
And,
Yeah,
you mentioned Amol Saxena. He was due to be visiting me, I think, either this month or next month. But I guess all travel's off now. So
yeah. Amal's a great guy. He, like I said, tons of information. I like I said, spent a year, 2 years actually at Palo Alto VA and Stanford, and learned a ton. Scrubbed his cases, and just really at the forefront of sports medicine. I'll tell you that. So I learned a lot of good techniques from Amal. And it's a bummer, with the travels. UK definitely will be on my list too. I'll come out and visit, especially the countryside. It looks beautiful.
I was hoping to do one of these with them all, but in person, in real time. But I'm going to have to video chat him now, I think. So we'll get him on the channel also. Michael, thanks so much. You've been really, really gracious with your time. You've been a fantastic guest to be on here. I think there's so much that we could have delved into that perhaps it's something that we need to do again 6 months down the line and catch up and maybe go down some different avenues. But I'm delighted that you took the time out of your morning to come and join us. So thank you very much.
Well, it was awesome. Thank you so much for having me. And like I said, the UK will be equal to the Southeast Asia trip. So it'll bring back memories. We could take a road down to Lancaster, and we'll walk down the spine at University of Lancaster. So
let's do it. Let's make a plan. After Freedom Day, we'll book some flights. Eh?
Sounds good.
All right, Michael. Right. Well, thanks very much, buddy.
All right. Thanks, Paul.
Farewell. Enjoy the rest of your day.
All right. You too. Thanks.
Bye-bye. Bye.
Bye.